Perfect. Thank you, Hiji. And then the last thing before we dive in is just a brief round of introductions. So if we could get our SNEs from the site to introduce themselves first, that'd be great.
I'm wondering, I did have to shave off a half hour of time. I think we all know each other by now.
That's fair.
I'm just wondering from the site, do we have Nicole or Heather Beaumont?
So neither of them are working today, and our PCC is quite busy at the moment, so we actually will not have a clerk or a PCC. It's just me, Suzanne, the manager, and Steph, the CNE here.
Perfect. And I think that will be more than adequate.
Mm-hmm.
Is there anyone on the CST side who is new to this meeting? I don't think we've got any new names. Okay.
I don't think so.
The fast version. Thanks.
Perfect. Sounds good. All right. So the purpose of a validation session, we're just going to review what we've built for this, OB clinic and the workflow. So the scope does include, registration, scheduling, the clinic visit itself, documentation, discharge, and follow-up. And that'll make more sense as we talk about what's in the body of this presentation. So starting off with a general clinic validation. So to validate, your facility is Richmond Hospital. Your unit description is the RHS 3 Birth Center. And this is how it'll display generally. And you'll have four triage rooms. You have 1, 2, 3, and then the fourth, which is kind of on the other side of the hall. Every M bed or birthing person bed does come with up to 3 baby beds, A, B, and C, which I haven't shown here explicitly, but do keep in mind that every M bed comes with 3 baby beds. And this is how your triage will look on the tracking shell. So you may remember tracking shell from the inpatient validation session, and we'll also put up tracking shell a little bit later on, kind of what it looks like when you're actually in the system. Any questions about this? Hopefully pretty straightforward. Take the silence as a no. And then to validate your clinical medical service is obstetrics. And then these are the positions to expect in this OB clinic or OB clinic. And so these are the roles, and then they'll all be associated with a certain Cerner position. Suzanne, you're the only one who would have a position picker, or you would have access to 2 different positions, one being patient care manager and the other being OB nurse. But otherwise, everyone else has just one position. So for example, OB nurse has OB nurse position. That's the same position for the educator and the PCC. OBGYN has the OBGYN position, so pretty straightforward in terms of role and position. Any questions about this slide? Perfect. And then we'll talk a little bit about registration. So these are what we call encounter types. And so an encounter, as a reminder, is a single patient interaction and or a series of visits to the health organization. So each encounter is assigned with an encounter type to indicate the patient's current level of care. So for example, an induction would have a separate encounter. If then that person needed an ECV, that would have a different encounter. So these are different encounter types and then how you would use them. Keep in mind, not listed here is every patient that is pre-registered for either a planned vaginal or a home birth will have a pre-outpatient in bed that's kind of separate from this pre-outpatient in bed. So every person will have a pre-outpatient in bed, and then they may have one of these encounter types if they require any like outpatient service, such as an ECV or an induction. So the pre-outpatient in bed, this one's for an OB induction that is not yet seen yet, but scheduled, and then that becomes an outpatient in the bed once that person arrives and registration activates the encounter, versus pre-outpatient OB, that is for ECVs, iron, beta-methasone, your blood, your NSTs, and those are appointments that are scheduled but not yet seen yet, and then those will get activated into an outpatient OB once they check in with central registration. And then you have your recurring ones for all treatments with 1 or more appointments. Any questions here about encounters?
I do have a quick question just about the encounters. Like, let's say somebody's come in for a pre-outpatient OB type assessment, but then they end up being admitted. Do you then change the encounter type once that's determined. I'm thinking like a ECV gone bad, bratty, code pink C-section, because I've had those before. And then she's admitted. How does that work?
So when the patient, if you decide that you're going to admit an outpatient, the outpatient OB encounter would need to be discontinued, or sorry, discharged, and then a pre-outpatient in a bed encounter would need to be created or flipped. So this is why we've got induction as an outpatient in a bed encounter type, because they almost always are going to stay at one point. ECV could be in that category as well if you would like. Other areas use it as pre-outpatient, but you can certainly book it as outpatient in a bed if you'd like.
I guess it would depend on how difficult it was to close that pre-outpatient OB and then open up another one. Like if central registration has to do that for us, then
your clerk can do it, or you can do it.
Okay.
It's very quick.
Okay, and we'll just leave it as is then.
And just to add, she should already have an existing pre-outpatient in a bed. If you said, for example, booked it as an outpatient OB appointment for the scheduled ECV, they when they get registered at 22 weeks, we already have a pre-outpatient in a bed encounter for them. So they would technically have it readily available. So if they, for example, needed to emergently, if they had to go to C-section or one, they could take that encounter. And then that way it's ready and available for them to use.
Okay. Thank you.
Yeah. Great question. Any other questions about encounter types? I'll take the silence as a no. Related to encounters are, why are we moving? Related to encounters are referral work lists. So this is something that's accessible in PM office. So often the clerk can access this. And these are work lists related to encounters. For example, there's one called past due arrivals non-surgery. That would be a list of encounters that are past their estimated arrival date time. So that's one of the referral lists that you can access to. And the other one would be deceased patients with active encounters. Now, hopefully this is not happening often, but if there were patients with a status of deceased, that would also show up in this work list as well. So this one, hopefully you're using this one more than this one, but these two you will have access to. And then when it comes to looking in the schedule appointment books, you might remember this from the scheduling session, and there will be a scheduling validation of session tomorrow as well. So we'll look at this a little bit more in depth. The scheduling appointment book, this is where you're scheduling your appointments. And so the bookshelf name, that's going to be called RHS OB Clinic, as you can see right here. This is something that the clerk would see. This is your appointment location. And then I think you said yes to automated appointment reminders. And this is the general view in terms of, you'll have options for your 4 beds, and then you requested a section for OB induction as well. And we'll look at this more in the demo as well. And in terms of appointment types, so this is a little bit of a busy table, and I'll kind of break this down here. So these are the proposed, different appointments that you would see in scheduling appointment book. So all the way from your iron to your different types of inductions, you have your ECV, steroids, and packed red blood cells. As a provider, this is the order I would place that would allow you to then, request this appointment. So placing an OB induction order and specifying what OB induction you want would then, trigger this appointment. So that's what this part of the table is showing. And then in terms of, and again, we'll look at this in the demo, this is where the clerk would go. So you would pick these filters essentially in scheduling appointment book to see the list of all requested appointments for OB clinic, for your OB clinic. So this is where the clerk would go. And this will make a lot more sense as we go into the demo and all the pieces kind of fall together. And the last part of the registration, in terms of the printing that happens at central reg and upstairs, and I think we might have talked about this before, so just to confirm, when they check in at central registration, that that automatically will print is an armband label and a face sheet. And of course, you can also choose not to print, but this will automatically print if you choose to print. And then upstairs, the things that will automatically print would be the 1 external use label, the 4 blood and non-blood specimen labels and 1 patient form label. And you can always print more. These are just the ones that default print out automatically.
I have a question about that.
Mhm.
So then all of the outpatients are going to be going through registration and will show up with a face sheet?
If you want them to show up with a face sheet, yes.
Yeah, okay. Yeah, I think we
Mhm.
do. Okay, great.
Okay, yeah. If you want them to, then yes, they can. If you didn't, we can also totally remove that. Best ideal
But
workflow.
that's regardless of their appointment type. It doesn't matter. They will still get a face sheet, whether they're an iron infusion or an ECV, it doesn't
Mhm.
matter. Okay, great. Sounds
Yeah.
good.
Yeah, and so ideally they show up at central registration and then they come up to you.
Perfect.
Any other questions about this slide?
Just with regards to labels, I understand that there's also going to be like a chartlet, like a thin or small binder where some forms will be kept.
Yes. Yeah.
Is there like a chartlet label at all or no? Chart label?
Yeah, that's what the patient form label is.
Okay. Thank you.
So the thing is that with anything that's printed from Cerner or from FormFest, which is the paper form printing repository thing, it comes with basically a label on it already. So you do not have to put another sticker on it. It already has the barcode and the patient information that you need there.
Perfect. Anything else about this slide?
I'm sorry, this is Jocelyn from registration. So just to confirm, you guys do want a face sheet to print at time of registration?
Yeah, I believe we decided on that at our last meeting, right, Suzanne? That we would keep the face sheet.
Yes, please.
Okay, thank you.
Perfect. All right, if there are no other questions about labels and printing, we will move over to your faxes and printers. So here your work queue monitor fax number, and I think the plan, I believe, was just to use your currently existing fax number, and this is your phone number. So just to confirm, these 2 numbers are correct. And as a reminder, your work queue monitor is like your virtual fax.
I believe the fax is 244 instead of 224. So it should be 244.
Okay, perfect. Thank you. I'll make note of that to get that changed. And then the phone number looks okay?
And the phone number 244-4133. Yep.
Perfect. In terms of like your actual printer number, we'll confirm that close to date because, like stuff happens to printers. You might need a new one for whatever reason. So we'll confirm that later on. And then you've also requested a label printer, and closer to the date, we'll actually get the actual number, serial number of that label printer. And then the types of requisitions that can print. So you have one that is paper, and this one is IPPDF. And then what that is an integrated print to PDF. So essentially it's like a PDF version of a requisition. So physical, you just have a PDF version. So those are 2 types of options that could print. And then you have your Sunquest Collect and single document scanning. So Sunquest Collect is related to when you're collecting any like specimens by the nurse. So it's like blood or urine and stuff like that. And so that is what you Sunquest Collect for. And single document scanning, it would be like if you had to scan anything that couldn't be done and like sent down to records. So you would have like you request a single document scanner for your unit. Any questions about that? Take the silence as a no. So diving more into work queue monitor, and again, I'll also show this portion and it will make more sense there. So remember that work queue monitor is your digital fax. So this will be the name, not currently built out in our build domain yet. This is a proposed name. And so the OB clerk is the one who'll be responsible looking at this digital fax. Although keep in mind the OB nurse position does have access to it, but really it's the clerk who'll be using it, and other sites it is generally the clerk uses it and not so much the OB nurse. And so when you receive documents in the work queue monitor, such as your antenatal records, the clerk will have to index them into the patient chart. And when you do that, you just kind of have to like classify them or put a label on these things. So that's what document type is. So say you received an antenatal record, you'd select the document type as antenatal document. And then more specifically in subject type, it'll be antenatal record part 1 and part 2. And so the purpose of this slide is just to confirm that we've kind of covered most of the document types and subject types that the most common things that be coming into your work queue monitor would be classified as. So for example, consent for blood products, you need to like scan that in because you need to write it in. So then once you get that consent, you'll scan to your work queue monitor or send to your work queue monitor, and then it'll be indexed as consent for blood products, consent for blood products. Everything in black here, these already exist. The ones in red, these are new and these are proposed subject types in the case where the provider chooses to fax a ECV booking form, an ST booking form, or induction of labor booking form. So that's why these ones exist here. Any questions about this? Anything that might be missing in terms of a document you would receive in your fax that isn't covered by these subject types or document types?
I suppose occasionally we will get from the OB offices some pre-signed consents and that kind of thing, like for C-section, although I know that they're also, if there's a scheduled C-section, they'd be in like a booking package, and that's how they usually come up. But yeah, occasionally I guess there would be the odd consent form, or sometimes like a breastfeeding / infant feeding consent form that we have might get signed in the office as well.
And something like, and this is, again, this is where it gets a little bit confusing because like OB clinic happens in the inpatient space, but for example, the breastfeeding form, is that something you'd see more often in like these outpatient OB clinic type patients, or more so for a patient in the inpatient space?
Oh, I suppose that could be inpatient space. Yeah, it's hard to like know because everything just gets faxed in and then it gets like sorted out.
For sure, yeah.
Like my office fills it, like we always get every patient to fill out one of those and then we fax them in from our office. So I don't know where that goes.
Do you have a copy of that form?
Mhm.
Is that something that's only you would have available in your private office, or is that something that Noakes also would also have in their office as well?
Noakes might, but I'm not sure if Noakes does fax those in or not. Might be
Like
a little.
it's a hospital form, like it's a Vancouver Coastal Health. Like
If
you
it's
just
a
ask
hospital
people if
form,
they, yeah.
Do we have a copy of that form, or
we would, yeah, somewhere, so
Okay.
we can
Mhm.
we can pull that up as well. I imagine really it's just about mapping each form to a
Mhm.
document type and a subject type.
Yeah.
So we can pull together some options for that. And if it's a VCH consent form, generally it's already set in stone. So we'll take a
Oh yeah,
peek.
we just wanted to make sure we had it available for Forms Fast if they use it
Yeah,
inpatient.
Yeah.
I don't know if it's a VCH form because it's, I mean, not a vetted VCH form because it doesn't have a form number or anything, but it's a unit, sort of like we made it, I think, on our unit like 12 years ago. One of those forms. So, but if you don't have it, I'm happy to provide. It should have been provided in the stack of papers.
Sounds good. We'll take a double check on that one, but thank you, Stephanie. Any other questions about this one or comments? If not, the last part before we go kind of the meat and potatoes of the session is message center. So message center is your way of sending messages to each other. Also, for example, if after this an NST done and the nurse needs to send that to the doctor for review, that will also be sent through message center. So there are different pool names. So one for admin, one for clinical, and one for the providers. And these are all the members that are in each of the pools. And the only thing we really need to confirm is the team lead for the providers. So the team lead is the person that is just allowing people in and out. So say like, for example, a new doctor comes in, the team lead will like allow them in, or like as there's movement. So ideally a team lead, someone who's not gonna leave anytime soon. Dr. Armstrong, I know you gave us 2 names before, but we can only have 1 team lead. So we're hoping that you could just like give us which name would be better for the team lead for the provider pool.
I mean, they're the co-department heads, right? That's why I said it. So I don't know if it really matters. I think Dr. O'Connell is more, and it's Dr. Hessel. I did ask them a long time back after this, and then I don't really even remember because it was like 4 months ago. I can look back in my messages and see if one of them thought they were better for it, but And it's Heslip, not Hessel.
Oh.
Laura Heslip, Heslip.
Apologies. Thank you for that.
Okay. Let me just check to see, because I did message them a long time ago about this.
Okay,
One second.
perfect. Yeah. If you have a name, if they preferred, that'd be great. Otherwise, you can volunteer someone. Yeah, unfortunately, there can only be one name in the message center pool. So that's the only thing we're hoping to clarify in terms of this. And then related to the message center pool is your clinic flag. So that's when they get admitted elsewhere, then you get a notification and that will go to your message center pool because you opted not to have that like print every single time. And so that's what this slide is about. But no changes have been done since the previous decision was made.
Oh, hi. Sorry. I'm just turn my camera off so I can eat my lunch.
That's all good.
So if there is a patient admitted, then you would get a message sent. Sorry, I missed that last part there.
So then there would be a notification that goes to the message center pool. So it'll be like a digital message that says like, hey, this person has been admitted. Some clinics choose to also have this like print out this one-liner piece of paper. Not necessary if you're okay with it only like going to the message center pool. So I think last time we talked about it, the decision was just for it to go to message center pool and not have it print out as well.
Okay.
If that's still okay.
I guess me as the sort of person, am I responsible for clearing those messages or doing anything with them, or that's just a notification that would be face forward for me?
So this will be a notification that goes to this clinical pool. So the RHS 3BC clinical. And so everyone in this, like, you could see it, but also other people can see it as well.
Okay.
So it wouldn't just be you, although because you are working Monday to Friday, that is a little bit more helpful in terms of like consistency, seeing it. Some nurses, even though they can access it, are like casual.
Stephanie, excuse me. This would be like you are the person that lets people in and out. It would be like the whole PCC group, for instance, would be a part of this and seeing the messages come in and out.
Okay.
If that makes sense, but you're just the gatekeeper.
Okay. I guess I'm also wondering about the sort of like relevance of these messages.
Oh, it
sense.
So what it does is it notifies you that your patient is, because they're admitted somewhere else, they're not going to show up for their appointment. That's the idea.
Oh, okay, got it.
Like you've got an appointment today, but then you get a notice saying that they were admitted to women's.
Oh, okay, got it. Okay,
you can cancel it. That's the idea.
Perfect. Thank you.
Yeah.
Perfect. Good question. Are there any other questions about this section? If not, there was initially a break here, but unless anyone really wants a 5-minute break, we can go kind of into the meat and potatoes of this and go into the demo. Are we good to continue? Yep, sounds good. All right, so we're going into the workflow validation. So we'll just talk really high level and then we'll get into the demo and a little bit more of the details. So from a very high level overview, the OP provider will place an order. So either it's going to be electronic or fax. And the clerk will receive this order. And generally, from what it sounds like, you guys do referral without triage unless there's bed limitations, but that you don't routinely do triage. So if there's like space in the beds, that's all good. And then the OB nurse and the OB provider will do your outpatient visit documentation based on whatever appointment it is. So in the case of electronic order entry, the OB provider, you're going to search for a pre-outpatient in a bed encounter. And remembering, like as Eve mentioned as well, that all patients 22 weeks are pre-registered with a pre-outpatient in bed encounter if they're planning on having a vaginal delivery or a home birth. So they have a pre-outpatient in bed encounter. And then from this encounter, you as the provider are going to place one or more outpatient orders. And you'll select Richmond as your scheduling location. There are some nuances. So for example, in the case of an induction, you might remember, but I will show again, the induction request auto text. So you're also going to create this in addition to placing your order. And then you can always CC or copy and paste this into your EMR. And in the case of an ECV, if needed, you would also place like a medical imaging, the ultrasound request to coordinate this with the procedure as well. And then any supporting documents. like your antenatal record, you're going to fax that to your work queue monitor. And so these are the orders that you can choose from in terms of these orders relevant to the OB clinic or outpatient experiences. So you have your fetal monitoring orders up here, your NSTs. Heather and Stephanie, I know you were part of the order sets session. That was kind of these were one of the orders that was talked about there. So this is under the works, as you might remember, and order sets is taking that on. You have your iron infusions, your red blood cells, your betamethasone. And then here you have your induction orders. So this one is for scheduling the induction itself. And then you'd pick one of these modules. For example, something like this one, you could order in a planned state, but obviously with induction, you're not doing that as an outpatient, you're just an inpatient. So if you really want to, you can put this in a planned state as you're putting the scheduling order. And then once they're, they're admitted, they can be activated then. And then these ones are your ECV orders. So your scheduling order, the actual module of the things to do on the day of the ECV. So you can order that in a planned state and the activated time of. And then this would be the ultrasound order related to your ECV that you would order as needed. And so this should really cover all generally the types of things that you do in this OB clinic. Any questions about this slide at all? I'll take the silence as a no. And so then the clerk, so after the orders are placed, the clerk would monitor in scheduling appointment book this request list. And I'll show what that looks like. And as long as the schedule can be, the appointment can be scheduled, you'll just select complete request and you'd create a new pre-outpatient encounter. So remembering that every kind of experience with the hospital or in the healthcare system, you'd have an encounter. So you'd make a new encounter, either pre-outpatient OB or pre-outpatient in bed, depending on what the type of appointment is. And then you would index anything in work queue monitor to the patient chart, like your antenatal records. And so I will do a demo just to put this all together, just to give a little bit more context to all these words. So just one moment as I switch gears. And we'll just take a look at what this looks like with an iron order. Alrighty. So hopefully you can all see my screen. So I'm in PowerChart. I am in as a doctor, as an OBGYN. And so I'm going to start by placing this electronic order. So I'm going to search for my patient. And best practice is by PHN. But for now, because this is a test patient, I'm going to search by name. And you're going to search for a pre-outpatient in bed encounter. So some patients might just have one encounter, some have multiples like this patient. So this one has a lot. So we're just gonna make sure we're gonna pick the right encounter. So this one is our pre-outpatient in a bed encounter, and I'm gonna press OK. If for whatever reason this person was not pre-registered and didn't have it, you just have to message the clerk to have it created. And so when I click on the counter, now I'm in the chart, and so I can see the name. I confirm this is the right encounter. And if I needed to, I can, of course, review information in the patient's chart as needed. For example, here, I can always review info, but if not, I can just go straight to my orders. And let me pull up OB quick orders. So different ways you can order orders, either from here, OB quick orders tab, or in this OB order section here. So we are going to order iron here. And if you really wanted, say this is for 3 doses, but if you really didn't want one, you could select here that I do not want to order it. For now, we'll keep 3. And when you press OK, you'll be able to do a lot of the modifications in here. So I selected the order. Up top here have, your vital signs, your infusions, the actual iron itself. And down at the bottom is your schedulable orders. So if for whatever reason there's something you didn't need, you can always remove it off here. But if not, you can keep it. And here's where you're going to put the details of the actual like requested date and time for each of the 3 infusion days. So I'll keep the date as is. Like no, you can say yes or no to interpreter. You'll fill in the schedule priority. Anything in bold with a star is for mandatory. If they were for whatever reason not getting iron done at Richmond and like somewhere else, yes, you could put an alternate scheduling location, but that's, from what I understand, not very common. And then this should pre-populate. Any special instructions you can free text. So I'm just going to put in these scheduling orders for the 3 days. Again, you can always change the date as needed. And when you're all done and you're happy with this order, you can press orders for signature. And then you'd press sign.
I have one question. So when you're putting in the dates, and forgive me if this was discussed before, but like, normally it's not me that picks the dates that they are. Like I just put like weekly for 3 weeks or something like that. So do you have to put in an actual date there, or because I don't know what date is best for them to come in for the iron infusion, right?
So in terms of the order, like the order does have to have a date, but then when you saw in the scheduling priority, you can pick like, you can put the date, but you can say within 1 week, and then the clerk will know to schedule within 1 week of that date, or within 4 weeks. So that scheduling priority will give you that flexibility in that sense.
Okay.
Does that make sense? Hopefully. Any other questions about that order or placing an order? If not, so the order is placed. And so now I, as the clerk, are going to look for this order request in scheduling appointment book. So I'm in scheduling appointment book here. When you select a patient, that banner will show up here. And you can see, for example, we're on the 23rd, and you can see what's already booked in here. So these are all test patients, but that's what it looks like when patients are already booked. To look for a scheduling request, you're going to go to Schedule Request Inquiry, which is a button you press at the top. And then I'm going to set my filters to find these requests for this clinic for RHS R3BC. So I've already preset them, that's why they populate, but once you have all these options, you're just going to press Find. And then what's going to show up is all the ones that are for this clinic. So you can see this person has a bunch of iron infusions. So you're going to pick on the right one. Obviously, it's not always just going to, you might see other patients. You're going to pick the person in question. For example, we are going to pick this one. And if it's good to schedule, you press complete request. We're just going to do this one for now. So I'll press OK. And the stuff that I filled out as the doctor, that pre-populates into here. So for example, the priority flows right over, the interpreter stuff, since I filled in, flows right over. And I just have to complete the mandatory fields, which is the stuff in yellow. And this will also be shown again at tomorrow's scheduling session. This is an in-person session. For the automated reminders, you would select yes, and then whatever number it is. And when that looks all good, you press OK. And now this becomes a work in progress. And then, so from here, you can either drag and drop it into whatever date you need, or you can press the suggest option, and it can also give you suggestions from there. So you can like pick criteria of the appointment, and then the system can automatically give you some options in terms of scheduling. So 2 ways, but whatever day you pick, I'm going to do the drag and drop, and then you'll just pop it. I know you do it on the hour. For example, you drag it in here, and then once you're happy with it, you're just going to press confirm. And press OK. And then from here, so now I've almost confirmed it, I'm almost done. Now I just need to create a new encounter, because again, at every visit, you have an encounter. So I'm going to just make a new encounter. This pops up because we're in the test domain, so just ignore that. And I'll just fill in the rest as the clerk. So there are some mandatory fields. They'll show up in yellow. Some is already pre-populated because there's already there's a pre-outpatient bed from the pre-registration. So a lot of that information already populates. You just really kind of just need to fill in the blanks here. And then you just press complete. So now it turns blue, our appointment's booked. The last step would be to index any supporting documents like the antenatal record. So for that, you need to go into your work queue monitor. Right now, there's none for Richmond, the test domain, so we'll use Lionsgate for now, but just imagine you're gonna have something really similar for Richmond. And then you're just gonna look for your patient. This is a test antenatal record, so this is what it will look like in work queue monitor. And then all you're doing is finding this person's supporting documents and then linking it or indexing it into the chart. This one is locked, but I'll show this one. So you just double click on the document you needed. You would then say, yes, this is for this patient. So you're going to link this to the patient chart. Making sure you pick the right encounter. And I believe we picked this one. So now we see the name populate, and then you're going to pick the document type. So in this case, we're imagining this is an antenatal record. So we'll say antenatal document. And then more specifically, it is the antenatal record, part 1, part 2. And you would fill in the rest of the steps. I'm not going to show all of it. And then essentially you're just going to press OK, and it's going to link into the chart. What that will look like now that our indexing is done is, let me open up Power Chart as, if I can find a nurse. So as a nurse, this would look like, and let me pick the right encounter. So as a nurse, if I want to find this antenatal record, it would be under documentation. And it would be right here. So that subject type helps you find it later on. And so then as a nurse or even as a doctor, I can review the antenatal record. And I can flip through the pages as needed. And that is what it looks like with electronic orders to scheduling. Any questions about that? And it will make more sense, especially, like boot camp and as, with a lot of practice and things fall into place. I
have a quick question. As far as placing the outpatient orders, I recall that you mentioned that not everywhere, like for booking NSTs and inductions, other places they still fax the forms in, right?
Yes. Yeah.
But Richmond is going to kind of be the first place that does it. Where you have to send it in.
Yeah.
So, sorry, go ahead. What were you going to say?
And I was just, as a caveat, there is the option for Richmond to also still continue to fax. So you can either electronic order entry or fax.
So is that, I'm just wondering, because this kind of changes a lot for us in our offices, right? Because like, and I know we talked about this before, but I'm just trying to get a sense of if this is it mandatory? Is it not? Because a lot of people, they're often like their MOA would be the one like sending in the faxes for these things. And it's a lot more cumbersome to then have to load up CST. And then I don't know if their MOAs are the ones that then do it, or usually people do it on their own. But I guess the short answer is nowhere else does it like that. So it's hard to say.
So for things like iron and betamethasone and blood, the ordering doctor does need to put in those orders into Cerner. There is no faxing of an iron infusion. Why can't I remember the PPO? There's no faxing of PPOs, and then no one's transcribing anything. So it is computerized provider order entry for those items. For an induction where there's no orders associated with it at the time of scheduling, the form is adequate. You can do that. But we're also adding the electronic way of doing it so that clinics like Noakes don't have to switch and do multiple systems. They're able to, you know, just stick in Cerner for all of their orders. And so UCC, for instance, they have similar things for their NSTs, where if they are at CW in the urgent care, the provider has seen the patient and decides that they want them to come back for a couple of NSTs at the clinic, they can put those orders in electronically and they go to the queue just like this.
And
So
that totally
there's
makes
a-
sense. Yeah,
it's
and
a transition.
I guess is it, so I just wanted to be clear. So it's an either or for the NSTs and inductions, and that would be up to the provider what they wanted to do in their office. Okay.
Yes.
Yeah. Iron, betamethasone, and blood is Cerner only.
Any other questions? I'll take the silence as no. So let me share my screen again. All right, perfect. And so just we were just talking about this with Heather. So in the, you know, in the case that you choose to fax the ECV, NST, or induction orders, you as a provider will just fax all of that and the supporting documents to the work queue monitor. And then if you really wanted to, you can then place, for example, the ECV module in a planned state ahead of time. You just have to log into PowerChart, search for pre-outpatient in bed, and then you could place the module to do the day of in a planned state. And then in the case of a faxed order, the clerk, you're just going to monitor the work queue monitor like the one we just looked at where the antenatal record was. The only difference when you're faxing in, so the nurse or the clerk will have to transcribe the information on the fax request form to scheduling appointment book. So unlike an electronic order entry where all that information like will flow into it and you just have to fill in the blanks, the clerk will just have to fill in everything and transcribe that. But then, you know, creating a new pre-outpatient encounter or pre-outpatient in bed encounter, that's the same. And then indexing into the patient chart, that's the same. So the only difference is being, yeah, the provider's faxing everything in and then the clerk just having to transcribe all the information from the scheduling request form in the case of fax. Any questions about the faxing orders workflow? No, perfect. So that's orders to scheduling. And now we'll just look at some of the orders to be created for this clinic. So the first one is the ECV scheduling order. So this is if you choose to do electronic order entry. This is what it currently looks like in the bill domain. So you have your requested start date and time. We couldn't have a section where there wasn't a time, so you kind of have to have a time in here. But if you're, you know, you can't just put 0001 as like a default time. You can put in your requested physician that you want for this. You just search their name. Reason for exam is going to be breach, but that's a mandatory field. And yes or no for interpreter, and then your scheduling location. And I will actually just pull it up in PowerChart so you get a better sense of what this looks like in the system. So where am I? I'm just going to grab my patient. And we're going to look at this order. So here is our ECV one. We'll look at that one first. And so when you select this ECV order, what pops up is this reference text. So we kind of talked about this reference text before. It gives scheduling information, and this is a bit small, isn't it? So let me actually pull it up here. So this is a bigger version of what pops up. So you have your clinic name, you have your phone number and fax number, and then your inclusion and exclusion criteria, as well as reminder to fax all supporting documents. this says nurse preparation, and it has to stay that way for it to trigger and pop up. If this scheduling information was selected, it wouldn't pop up for you. So that's why if you see this, this is why that's there. And for, if I can find it. Oh, where are you?
I just have a question
Mhm.
for when you have to include the date and time of the
Mhm.
booked ultrasound. Like, I mean, usually when you're booking the ECV, you're kind of doing it all at once, and you don't know when the time is for the ultrasound. Like, just I'm just thinking when I've booked them recently. Like,
Mhm.
I send in the ECV form, I set, and then I wait for ultrasound to tell the
Mhm.
birth center / me what time the ultrasound is going to be. So I don't usually know. So I guess you just put in special instructions to be determined by ultrasound, or
Yeah, so if, in the case, if you did know when it was, you could put in the special instructions. If you need to order ultrasound, there is the ultrasound order. And then, yeah, you can put in the special instructions to allow for that coordination. But when you are booking it, you would also put the separate one, and then you would also put the request in there. So let me just pull it up. Ultrasound.
And Heather, at the last session, the clerk confirmed that that process for coordinating would just stay the same. You send in requests for both
Mhm.
at the same time, and then they will do the rest, and then let you know
Yeah.
when it's.
Mhm.
okay, great.
Yeah. So you just put in this other one as needed. Mhm. And so now you have your Richmond scheduling location. So that is that one, ECV one. Any questions about this one? If not, we'll show the other one. So the other one is one for inductions. Schedule procedure. So likewise, really similar to the ECV one, when you select on it, this reference text will pop up. Again, with the clinic name, the phone number, fax number, your inclusion and exclusion criteria, as well as reference to filling out the auto text, which is kind of like your request form with the information on it. Is this text size okay? Do you want me to show a bigger blown up image of this reference text?
I think it's okay.
Okay, I'll take this out since it's okay. Any questions about this reference text here? I'll take the silence as no. And the other thing about this reference text is if you like, oh, I forgot what it looked like, you can always click on here and then you can pop it up again. So it's not like once you close it, it's gone forever. So in here, again, we couldn't, remove the time. So we just put in, so that has to stay there. In terms of reason for exam, it's whatever, reason is most applicable. Say it's post dates. This is a free text option. If they need an interpreter, yes or no. Your scheduling location. And so this still needs to be kind of decided. Like we talked about, I think there's preference from the site to like ideally have stat and within 8 hours as options. And that is a ticket that still needs to go through the process. So right now this is just like the stock list, but we have of course curated down to either the 2 options if the ticket doesn't go through or all 4. So this is still a work in progress here. So that will look a bit different, more applicable to this clinic. But these we have made so the different appointment types in terms of your induction. So your ARM, your Cervidil, Foley, Miso, Oxy, and Prostin.
I just wanted to point out that the requested start date and time there is, it's pre-filled, it's optional.
Mhm.
The clerk doesn't really pay attention to that as much as they do to the priority. So they will get the request and they will see the priority is, within 3 days, and they will go with that.
I guess my only thing, like sometimes we are like say I see someone and I know I'm going to be inducing them in a week or 2 weeks or something like that. Like I don't know. Can you put on like the priority? Because usually we put in like the date maybe that you want the induction to be, or say, yeah, like say I'm planning for an induction. Say they're 37 weeks and they have hypertension. I'm going to induce them at 38 weeks, and then I say, oh well, I might as well induce them next week, 38 weeks, the day that I'm on call, or something like that. Like it doesn't matter, but sometimes you just put in that date. But I don't really see a space to put that unless you were putting the requested start date and time and you did put something specific there.
That is a good point.
Just because the time, it just seems limited with the time, like because I know it's hard to capture that, but sometimes you'd say like, okay, it needs to be you know, as soon as they're like sometime after 38 weeks, so it needs to be like the priority is still higher, but maybe you're planning it a week in advance. I mean, I guess maybe you sometimes just can't, you have to wait, but that's my only thing. I just don't really know how to capture that in here.
So hi, this is Sharon from Ambulatory. We can add a special instructions field to this, just like you had on the other order.
Yeah, that would be helpful, I think.
Okay. Okay, thank you.
And
That would be
Heather,
great.
the priority options that we had gone with, there was the 4 things, and I think the longest was within 72 hours. And that's because that's what's on the form. But are you like currently using that form? Are you scheduling it differently? Like and maybe scheduling 2 weeks in advance?
Well, I mean, I think if you already know someone needs like sometimes you do it like the week before or you know, a little bit longer than a few, like the priority is still the same, like that, you know, as of whatever date you're requesting it for, the priority would be 24, 48, 72 hours, but you're planning it a week in advance or something like that, or 2 weeks in advance. Like if they're like if they're advanced maternal age and you're going to induce them at 40 weeks, then you know, I mean, it's more, it doesn't always come up that often, but I'm just trying to, that's the only thing I can think of that maybe the special instruction one you could put on there. And I guess you could put the requested start date and time, and you could put the date that you are requesting for, right? And you know, put in the special instructions, like say if I wanted it to be for, or I was booking it, I saw someone in my office today and then next week they're going to be 38 weeks and I was going to induce them then I could just put it in, okay, I want November 1st, whatever, I would put it in the requested start date and time.
Gotcha. I don't want to like take us right off the rails, but we could add additional things into that priority field if you think is common enough that you'd be using the as per special instructions option all the time. So in the, like we could add, you know, within 1 week or something like that, so that
I think it's hard though within the 1 week though, because sometimes you're just giving specific dates, like sometimes I would be putting, you know, once they're 38 weeks, you know what I mean? And then so that would be, I would know, okay, November 1st, they're 38 weeks. But then sometimes there's a discussion with the patient over certain factors and you kind of decide on, okay, 38 and 2, if there's availability, that would be the best date for us to plan for the induction, right? I just don't know where to capture that in here per se.
Sounds like the free text special instructions field is the best thing.
Yeah.
And Emma, just to let you know, to add anything to that priority field, we'll need an EDD.
Oh, I mean, just the
what's already there.
Not add anything net new.
Oh, okay, got you. Sorry.
Well, that was a great discussion that came out of that. And also remember that associated with this is the auto text. So I will just pull that up as well. So you'd go to documentation, you would click add, and then you would pick your obstetrics clinic note as an option, and then you would just title it like OB induction request. And this is a free text option, but it is, helpful of everyone when they do this auto text, like types it the same just for ease of finding. So does this name work as the title of this request documentation?
Seems
And this
good
would
to
be
me.
perfect. Yeah, that's the one we would then recommend to everyone. So just easier to find when you're looking back, and then you press as a free text note. So you'll get this blank page initially. You'll press comma, comma, and it is and so when you type enough, it'll give you a filtered list where you can find it. And it is also in the reference text if you forget. And then when you double click on it, this would be your auto text. So as a reminder, these things auto-populate based on what's already in the chart. And so usually that stuff would, because most of the time they're pre-registered by this point. So this information will already be in here. If your drop downs, so these have all 4 with reminders to call the unit in the case where it's like immediate or within 8 hours. Something like this is free text. So like kind of like you're talking about Dr. Armstrong, like gestational age at the date of induction. So say it's like 38 weeks or whatever have you, this has to be a free text option. You have your reference to your Bishop score and then all your drop downs here. So after you kind of do the math, you just pick whatever number. Your induction method requested. So these are the same as the ones in the order. Cervidil. And then whether or not it's like a low risk or high risk indication. And because this is a free text, at the end of the day, if like I'm an OB, I'm not doing a low risk one, I'm picking high risk, you can just delete this after. I'll just delete right off. But these are the options for low risk. And I'll let this hang out for a bit just to validate that this looks all okay.
Just a question, like, do people have to fill this out if they're an inpatient? Like if like you see someone in triage and they have a rupture of membranes and then you're booking them and it's an induction. Do you have to and I guess my other question is that how people have to come up with how to fill out this form? Like they have to know to look it up and then do the comma and then enter it? Because I feel like people are not gonna that seems hard to remember. Do you know what I mean?
It is, yeah. So when you initially pull up the order and that reference text pops up.
Yeah, it tells you to do that,
Yeah,
right?
it tells you to do that. So let me just, so in here, this is the reference text that pops up and it does say the required auto text with all of this in here. Because for sure in the beginning, it's hard to remember. So that's how we include it in here.
Okay.
And even though you close
it just seems a bit hard.
Yeah, it is
Yeah.
for sure a change in practice.
Like I would say, like if I have the option in my office, I'm gonna fax the form in rather than doing all of this because it would be a lot easier. But I'm not in the Noakes clinic, right? So I don't have to. But it just seems very. I mean, I know that there's not really another way around it, but I guess it just seems really to fill out the one form and then search up and then write in that one and then fill it out. I know that there wasn't a way of capturing it on that other form, right?
Yeah. Yeah. This is, by no means the perfect solution. We could also call it like internal kind of orders. This is more often placed like when you're already on site. So that's versus like in your clinic, although you can do it from your private clinic. So this kind of workflow is more used when you're again on site. And there are other.
So even if you are on call, like and you're in the hospital and you're booking an induction, you still have to fill out this referral _ RHS OB clinic IOL form.
If you're
I guess
choosing
not necessarily, I guess not necessarily.
Like for an inpatient that's actually being like already has been admitted, that kind of situation.
Yeah. No. Okay.
No.
Okay.
So this is for like the outpatient.
Okay.
And yeah. If they're like, say you see them in triage and you didn't already have a pre-planned induction, but like now you're like, hey, you
Yeah.
should probably be induced, then
Yeah.
this doesn't count. Then you're just
Then
going
it
right
doesn't.
into like
Okay.
an inpatient because you're admitting and then you're starting
Got
all
it.
of it.
Okay. Okay.
It's as
Okay.
if it's more like, oh, like, yeah, exactly. For example, like, diabetes, and they need an induction and you're
Okay.
planning that in advance. And this is kind of where
Okay.
this goes. Yeah.
Okay.
And even though like other sites that do inductions don't do this workflow, there are other VGH clinics that do something similar with an included reference text as well. But again, not by no means that we're saying this is a perfect solution, and all valid, feedback based on this. Let me just, do we need to look at this again, these low risk induction indications? And this is all like copying from your paper form. So your proms, your post dates, your mat age greater than 40, and then you have your high risk, a bigger scroll down. And anything that wouldn't be covered in here, you can free text in the other induction indication.
And I think, I don't know if I mentioned this before, but can that be alphabetical or something? Or is it, because it just seems weird. You just have to scroll through all of it to find the right one that you want.
We can make it alphabetical if that's more helpful.
I mean, I think it's because I don't think there's any rhyme or reason to the way that it's listed there. So I feel like alphabetical would be maybe the most helpful if you're having to scroll. I mean, you might end up just, or like the most common ones just being at the top or something like that. Like hypertension. I mean, I guess it's kind of like, maybe that's how it's set up.
Yeah, right now these are kind of grouped with like
category
type-ish. Yeah.
Yeah.
But if alphabetical is more helpful, we can do that.
I think either that or the most common ones at the top, like hypertension, diabetes. I'm happy to look through and just see, but
yeah, sounds good. Yeah, we can reorder these.
Yeah, you can send those to me, Julia. Once you get
sounds good. Yeah.
Yeah.
Yeah, for sure. Yeah, but we can totally do that. Is there a preference between alphabetical versus most common?
Maybe most common at the top, because there's like a few that are like really common, and then there's some on there that are very uncommon.
Okay. Are you okay if I send you an email later, Dr. Armstrong?
No problem.
With the list? Okay, perfect.
Yeah.
Awesome. And the last one is yes or no, appropriate for outpatient. And this is just like a direct copy of your table that you had on your paper form for your reference. Any other questions about this auto text? I will take this silence as a no. And the last one that we made for this clinic, and Dr. Armstrong and Stephanie, you might remember seeing this at this the order set session, but those are the NST orders. Go. We have 3 modules. One is for singleton, one is for multiples, and then one is for post dates. I'll just show this not in too much detail because a lot of the feedback's going to be, coming and going from the order set session. And it's still a work in progress. And I know there was feedback about, changing this and having something for Richmond with more than just 2 weeks. But as a reminder, this is what this one looks like, and with drop downs for Richmond as an option. And when you select on it, then you would kind of fill in the rest. But again, more work will be done on this with the order set sessions that they'll be coming in the future as well. Any questions or comments about this one?
Hi, it's Steph again.
Mhm.
I guess I'm just wondering how these would display up on the scheduling queue screen. Because you have NST for singleton, NST multiple, and
Mhm.
then NST post dates. So within the NST, let's say singleton, there could be a wide variety of reasons for that person to come in for NST. Does that show up forward facing, like for the
Like the reason
person
for
on
them.
the reason? Yeah.
Mm.
It's I'm just wondering because with our current workflow, we do put them into
Mhm.
the calendar with their name, but also the reason for their NST.
I see.
So the fields that you see in the blue bubbles are
Mhm.
quite customizable. So you can pull in all sorts of stuff
Mhm.
from the scheduling order.
Oh, okay. So if we had like a reason for exam or whatever reason included in the blue bubble.
I think you can, yes. And I mean, the appointment type is there, so it will be NST multiple, for instance.
Right. Yeah. I'm just wondering
Versus
more
singleton.
for like the singletons, because like you could have somebody coming in for I don't know, blood pressure, diabetes, IUGR,
Mhm.
polyhedral nose, oligo, like a whole bunch of reasons. So
Right.
it would just be nice for the clinician to kind of have a heads up as to who this person is and why they're coming.
Mhm. Mhm. Yeah, I can see that. It's a good point. It's something I can confirm as well for you.
Okay.
And also there'll be the scheduling session tomorrow as well. And so if I can't confirm it before then, I can also
Okay.
confirm it then as well with Simone. Yeah,
Julie,
yeah.
hey Julia, this is Amy.
Okay.
Can you just try
Mhm.
hovering over the blue? Yeah,
Yeah,
it shows more information there. So
a little bit. Yeah.
I think it's because it's a 1 hour appointment, so it doesn't list all the
Mhm.
information. But if you look at the blue box on the right, it lists everything, including I'm pretty
The
sure it
free,
lists the reason for exam there.
free text. Yeah.
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 Oh, I see. Okay.
Yeah, if you just
Yeah.
hover, it'll show more
Mhm.
information. It's just because the
Yeah.
blue boxes on the left, it's just they're shorter.
Mhm.
Because they're just 1 hour appointments. But if you
That's a good
hover,
point.
yeah,
Yeah.
it'll show everything.
Mhm.
Does that make sense?
Oh, okay.
Yeah.
Yeah, I guess we can kind of see how that plays out for the go live. But if that was something that our staff wanted to have be a little bit more visible, would that be possible to add in later? Like as being
Sharon.
more forward facing versus having to hover.
I believe it's super customizable by each person. So you can choose to see as much or as little as you want. Which is something that we can do during the training sessions.
Okay.
But for the most part, clerks are referring to this page, but nurses are looking at ambulatory organizer
Mhm.
or the schedule. So they will see that information there. And I think
Yeah.
that's kind of
Let
maybe
me
what
pull
we
it
need to
up.
focus on, making sure it's got everything.
Yeah.
Yeah, so that reason for visit pulls into the notes side.
Yeah.
Oh, I see. Okay.
Yeah. So nurses can look at schedule appointment book. That is always an option. But nurses also have this view as well that I was going to show. And so you can see what's coming up. Obviously nothing booked there, or you can see previous days or today. And then it shows you in order. So it's like a condensed view
Okay.
of who's coming as well.
And can that list be printed off? Or no?
It can, but wondering why?
I guess, well, how we have it right now is that the PCCs will print off the calendar for the upcoming day, like the person on nights or the person on days. So then we pull, all their files, which I guess wouldn't be happening here because all the files would be in the electronic system. But I guess maybe it's because I'm still very entrenched in paper. But the way that we kind of like organize our brains is around paper. So
I
Right.
think you'll find that it fundamentally is going to change.
okay.
And so
But
everyone
we
will have
won't need to
access,
print out this list and have it be posted.
because
Your
everyone will have
said.
access to this list on
Yeah.
every single computer that they log into.
And it's just a button you press up here. So if you want to see ambulatory organizer, you press a button up here. Or as you as the PCC say you want to look at tracking shell, then you press tracking shell, then you'd go to tracking shell.
Okay.
It is different for sure. Yeah. Yeah.
0 paper. Okay, got it.
Yeah,
You'll still have
Stephanie,
some.
once-
You'll still have your chartlet. Less paper. Less paper.
Less
Yeah,
paper.
Stephanie,
Yeah.
just to give you an idea, in terms of like women's, yeah, once we kind of went towards CST, like one of the things that they had to do was like prior to the night before, you normally the chargers would check like the book just to see if anyone was booked for like any appointments, like up in Evergreen, for example. So, and most importantly, it's because they do IVIG. So now part of their workflow was that they don't have that paper book anymore. So instead, what they would do is the night before, the part of their checklist was they would go into refer like to ambulatory organizer and see that if anyone for the next day is booked for an IVIG. So it kind of becomes entrenched as part of your new workflow.
Okay. Got it.
Mm-hmm. Yeah, a lot of great conversation here about it. So we looked at all the orders. Did anyone need to look at the NST orders again, keeping in mind that we'll see this again in order set sessions? I'll take the silence as a no. So essentially, you place your order, you schedule your patient, and then the patient actually arrives. So remember, patients will check in with central registration and they'll activate this encounter to outpatient and in bed. And then they'll come up and essentially just the clerk will check them in. The clerk will put them on the tracking shell and then we'll update the status as needed. And remembering that that kind of looks like, so they'll show up somewhere here, just like this patient is doing. And then you just change the status to whatever you need. Say it's like an induction, and then you change it to induction or infusion, and I have the infusion down here. And so they'll change color depending on what they are. They also have it here for a little bit more detail. We also looked at this at the birth center validation session. Again, ambulatory organizer, so the other way of looking at your schedule for the day. And then you as a nurse are just going to do what you normally do, is just going to look a little bit different using power charts. So you still, if you need to put them on the EFM, you're going to put them on the EFM. You're just going to use fetal link with that as well. So different application related to the fetal heart rate. You're going to review your information in power chart. You're going to look at your orders like you normally do, but that's just going to be on power chart. And then you just do your charting. Same charting as you would, just different place and a little bit different. And so, for example, remembering that a lot of your charting is going to be in iView now with all the check boxes. So say you do triage, you need to record some fetal monitoring. You're going to pick what you need and fill in what you don't. Like, for example, if you don't feel presentation, you don't have to fill that in. So you fill in what you need here, your contraction information, all that. So all your charting is going to be in here in iView. And if you need to do any medication, you will do it in the medication administration section, scanning their armband. If there are any medications, they'll show up here. And reviewing your orders. So reviewing your orders, you go to the order section. Instead of flipping through the chart, you're just going to go into this section. And for example, in the case of iron, you are just going to activate the orders. And just review them. And then once you activate them, you press 9. So these are the orders that the doctor has placed. So again, workflow-wise hasn't changed other than like, where you're looking for them. But you're still following site policy in terms of like monitoring, patient care, all that. And then your triage and assessment form is now just a digital form. So that power form, you might remember I showed it before. So that's just all going to be also in power chart, a lot of check boxes. So instead of handwriting it, you're filling out a power form. and again, iView. So power forms and iViews really where most of your charting is going to be captured. In the case, you know, especially for nursing, if you had to write a narrative note, you can create a narrative note, although that doesn't flow to as many places in PowerChart as iView. So it's always recommended to try to do iView first. Providers, if you need to write any notes, you do have different documents that you can create, as well as social work. And some of them, most of them distribute, not all of them do. But these are the most common ones you're going to use. And when you're ready to discharge them, you're just going to discharge them from the tracking shell, and then you're otherwise going to follow whatever site process you currently use for discharge. And if there is any other future appointments, you can confirm them by looking at a schedule appointment book. Yeah, and that is it in terms of the overall workflow. Any questions about that?
I guess I do have a question, Steph, again. With regards to discharging a patient, let's say after her NST. So what we do right now is we would keep her antenatal file as well as the paper copy of the tracing in a basket that is, you know, aptly entitled NST is not read basket. And then the OB on call will then, when they are around, come to read them and sign them off. How does this look with Cerner? What's the method of, I guess, flagging those strips to be signed off?
Yes. Yeah. So in the case of an NST, so the nurse is going to put the patient on EFM, and then you're going to finalize that tracing. And then if you remember, we talked about message center, you're just basically going to attach that finalized strip and then send that in message center to the provider to review. And so they're going to get that in their message center.
Oh, I see. Okay.
Yeah. So instead of paper, that's just going to go there.
It just goes directly to them.
Yes. Yeah.
Okay.
Great question. Any other questions?
And just to clarify, it goes just they send it directly to the person who's on call that day that's responsible for it. Is that correct?
It goes to the group, and then whoever's on call is responsible for reviewing the inbox each day.
Okay.
Any other questions? If not, there is one last thing, and that is just some reports you can print out. Really these two, and you can print them ad hoc as needed. So one of them is scheduling statistics, another one is scheduled by location. So these are just ones, if you do need them, you can print it out. This last one that is normally printed out because you're just getting the clinic flag, because you're just getting as a message center notification, and we decided not to have it auto print, so this one is not applicable. So really just these two as needed, and the positions that can print them out. So let this one hover for a bit. Any questions about these reports at all? I will take the silence as a no. And that is it. Any questions for us that wasn't covered in this presentation or this session? If there's no questions for us, actually, I did have a question for your site, just to confirm the level of nursing involvement when it's a midwife patient. So if it's a patient that is under midwifery care, is it generally that there's a nurse assigned who will do the same type of like intrapartum care as if it was like a GP patient or an OB patient, or is there different levels of involvement depending?
I think there's different levels of involvement depending on the midwifery care provider.
Okay.
Yeah.
And depending on the patient, if the patient was being induced and was a midwifery patient, they obviously would still get the same one-to-one care.
Mhm. But if it was like very low risk.
Low risk person,
Mhm.
yeah, I think it depends on the midwife because some of them will do their own triage and assessments, like initial assessments,
Mhm.
and document everything. And the nurse really doesn't need to do anything.
Mhm.
But other providers are more hands-off, let's say. And
I
we
see.
would
Okay.
report off to them as if they were a medical provider.
I see. Okay. So case by case kind of basis.
Yes, it is.
Mhm. Okay.
Thank you. It just gives us an idea of training requirements.
Mhm.
Great. And then we're meeting tomorrow to talk about validation for,
Scheduling for this clinic. So the scheduling OB clinic validation session.
And then an email will be sent out from the order sets team to validate the NST order set.
And I'm not on that one tomorrow, right?
No.
Okay, good.
Unless you want to.
I'm good, thanks.
I did do an
your
overview of the scheduling appointment books. You get like some sense it'll go deeper into that kind of stuff. The scheduling and the.
great.
Yeah.
Thanks, guys.
Thank you.
Thanks,
Perfect.
everyone.
Thanks.
Really appreciate all of your input.
Thank you.
Thanks,
Tomorrow.
everyone.
Mhm.